السلام عليكم ورحمة الله وبركاته. Actually, this is one of the most important session in the diabetes mellitus. A lot of a question from this session in the final exam, and actually this is the last session in the diabetes mellitus module. And inshallah, in the next session, I will cover June 2024 exam recall. The previous exam, and actually in the final exam, a lot of a question from the previous exam. I would like to start my session today by this slide. أتظن أنك عندما أحرقتني ورقصت كالشيطان فوق رفاتي وتركتني للزاريات تزرني كحلا لعين الشمس في الفلوات. أتظن أنك قد طمست هويتي ومحوت تاريخي ومعتقداتي عبثا تحاول لا فناء لسائر أنا كالقيامة ذات يوم آتي. رحمة الله على الشهداء. My session today is a part from a preparatory course for European Board and Subspecialty Examination, and don't forget that my tools, files, and videos are not for a distribution. It is for your personal use only, and this is interactive presentation, so any question at any time are welcome. And let's start from some of MCQs from the previous session. This is a question related to 44-year-old male presented with a 4-year history of type 2 diabetes mellitus with symptom of nausea, vomiting, abdominal discomfort, and lethargy, and a progressively worsening. Random plasma glucose is not elevated, and also fasting blood glucose is within the target. Hemoglobin A1C is within the target. The patient already in glimepiride, metformin, and empagliflozin. And actually, the patient most recently start ketogenic diet, less than 30 grams of the carbohydrate daily. The body mass index is obese. Which of the following is the best next step to evaluate the patient sample? Type 2 diabetes mellitus on sulfonylurea, metformin, and SGLT2 inhibitor presented with vomiting, abdominal discomfort, and lethargy, and progressively worsening. What is the best next step? Basic metabolic and banal and serum beta hydroxybutyrate measurement, C-peptide, CT of the abdomen and the pelvis, urine analysis, point of care plasma glucose measurement. What is the best option?
Eoglycemic DKA?
Yes, this is actually the typical presentation of Eoglycemic DKA, so we should exclude it by measuring beta hydroxybutyric acid and basic metabolic panel. Don't forget that this is essential to exclude DKA in every patient receiving SGLT2 inhibitor and presented by some manifestation of the abdominal pain, colics, and so on. Don't forget this, euglycemic DKA. Another question, this is a 28-year-old woman presented with a recent hospital admission for diabetic ketoacidosis and newly diagnosed diabetes. The patient is rheumatoid arthritis, hypothyroidism, and paternal grandfather has type 2 diabetes mellitus, diagnosed at the age of 40. Hemoglobin A1C is very high, C-peptide is low, C-peptide is low normal regarding the reference range, plasma glucose is mildly elevated. The body mass index is 37, obese. The patient on insulin glargine, 30 units with metformin XR 500 milligram twice daily. The fasting range from 85 to 112. There is no antibody for autoimmune diabetes has been assessed. Which of the following is the best next step? Measuring fasting glucose and insulin. What is the value of measuring fasting glucose and insulin? To calculate HOMA-IR. HOMA-IR is calculated from the fasting plasma glucose and fasting insulin. And actually, HOMA-IR as a parameter for insulin resistance is not a right answer in any question. measure insulin autoantibody, measure C-peptide and glucose, add prandial insulin as sulfonylurea. In this category, the patient present with DKA and the newly diagnosed diabetes mellitus. Insulin antibody, actually, the insulin autoantibody has no value in any patient on insulin therapy. The insulin autoantibody, it may be due to the endogenous autoantibody from endogenous insulin, but any patient received exogenous insulin, measurement of insulin autoantibody will be has no value. Don't forget this. Don't measure insulin autoantibody in a patient received exogenous insulin. Yes, Dr. Sherihan, you are right. Measurement of C-peptide and the glucose is the right answer. The
Because
patient,
C-peptide in acute state may differ later on.
yes. Actually, this may be type 2 diabetes, ketosis-prone diabetes, may be presented by DKA. Actually, DKA is a manifestation of absolute or relative insulin deficiency. It is usually presented in a patient with type 1, but in some situation in type 2 diabetes mellitus may be presented with type 2 ketosis-prone diabetes mellitus. So measurement of C-peptide which reflect the beta cell reserve, if it is elevated, it is a type 2 and we can stop insulin therapy and the patient converted to only oral antidiabetic medication, metformin plus sulfonylurea or metformin plus any other medication. So don't forget that in a patient like this C-peptide is low initially when the patient admitted to the hospital. But nowadays, it may be have some sort of beta cell reserve. C-peptide will be normal. So in this situation, we can stop insulin glargine and convert to only oral antidiabetic medication. Another question, a patient with cystic fibrosis related to diabetes mellitus. And actually, in the final exam, as I mentioned, all patients of cystic fibrosis, if presented with hyperglycemia, this should be managed by insulin therapy. But in our case scenario, cystic fibrosis related diabetes mellitus becoming pregnant, cystic fibrosis related diabetes was diagnosed when she was in college based on 2-hour glucose, which is elevated to 232 with oral glucose test. And the patient, she recalls being prescribed basal insulin, but she developed hypoglycemia. If any patient presented with hyperglycemia and received insulin therapy and present with hypoglycemia, what is the best next step? To decrease the basal insulin. Currently, she take only prandial insulin as part at a dose of 1 unit per 15 to 20 grams of the carbohydrate, and the fasting plasma glucose is well controlled, 90 to 100. And postprandial is between 120 and 180, so within the target. As you know, the target in any patient with diabetes, postprandial should be less than 180, and the fasting between 80 and 100 CR. Which of the following should be initiated at a time of a pregnancy as the best next step to improve the glycemic control and the neonatal outcome in the patient? Basal insulin, continue blood glucose monitoring, continue subcutaneous insulin infusion or insulin pump, hybrid closed loop system, increase self-monitoring plasma glucose to 7 times daily. Which is the right? Yes. The hybrid closed loop system is not recommended actually in this situation. This is a pregnant female, so the hybrid closed loop is not recommended. Continuous subcutaneous insulin infusion or insulin pump therapy, the patient is not in pump therapy actually. don't initiate insulin pump during the pregnancy in a patient not in this maneuver. The patient blood glucose is okay. So actually, as mentioned by Dr. Sherihan, continued blood glucose monitoring is the best step. If the blood glucose is out of the range, according to the pregnancy, we should start basal or prandial insulin according to the hyperglycemia. During the pregnancy, fasting should be less than 100. Postprandial 1 hour less than 140. 2 hours should be less than 120. This is actually by milligram per deciliter, and we can convert it to millimole. If the patient is out of these targets, we should initiate basal bolus according to the hyperglycemia. If the fasting within the target, we can start prandial only and so on. Today's session, inshallah, I will cover diabetes neuropathy and the proximal motor neuropathy and the management of foot diabetes and Charcot foot and so on. The diabetic neuropathy is definition is involvement of cranial, peripheral, and autonomic nerve, and it may be found in diabetic patients, so termed diabetic neuropathy, and predominantly mainly sensory neuropathy, sensory peripheral neuropathy. The commonest clinical consequence of neuropathy are altered sensation. The patient may sensitize in pain and may be insensitive to normal sensation. A neuropathic ulcer usually in the feet, erectile dysfunction, and Charcot arthropathy. And of course, we can classify the patient of diabetic peripheral neuropathy, into diffuse neuropathy, autonomic neuropathy, like posture hypotension, esophageal dysfunction, gastroparesis. This is a very common question in the final exam. Erectile dysfunction, neuropathic bladder, and mononeuropathy, which usually affect one of the cranial nerves and sometimes an ulnar nerve causing a carpal tunnel, or lateral popliteal nerve or femoral nerve causing what is known as diabetic amyotrophy. And actually, this classification mentioned in Oxford Handbook. Polyneuropathy, usually the most common is peripheral sensory motor neuropathy. It is combined with large and small fiber neuropathy, predominantly large fiber or predominantly small fiber, and I will cover this later. Autonomic neuropathy, like cardiovascular autonomic neuropathy, resting tachycardia or orthostatic hypotension, sudden death, gastroparesis, and may be present with diarrhea or constipation, bladder hypomotility, erectile dysfunction, and focal neuropathy, as I mentioned, mononeuropathy multiplex, and intra carpal tunnel syndrome and ulnar neuropathy. And actually, this is a picture from the Oxford textbook for diabetic truncal polyradiculopathy. The pathology of diabetic peripheral neuropathy, usually microvascular complication of diabetes mellitus causing distal axonal loss occur with focal demyelination. So it is usually peripheral and distal. The vasa nervosum often show basement membrane thickening with some sort of endothelial cell dysfunction. There is a lot of pathogenesis. Several possible mechanisms have been suggested related to accumulation of what is known as ACE, acute ischemia of the nerve, causing vascular abnormality, and insulin may be presented with, if we initiated insulin recently, it can cause insulin neuritis, which will aggravate peripheral neuropathy. Peripheral sensorimotor neuropathy, this is the most common. This is a chronic sensorimotor neuropathy known as diabetic peripheral neuropathy or distal symmetrical polyneuropathy, which affect over than 50% of the patient. Around 30% of the patient have either symptomatic neuropathy or abnormal on examination. And of course, the duration of diabetes is the most important factor in development of this neuropathy. Feature of peripheral neuropathy, and don't forget that this tool is very important, tuning fork and 10-gram monofilament for examination and assessment of peripheral neuropathy. Peripheral sensorimotor neuropathy usually insidious, presented with numbness or paresthesia, start in the toes and soles of the feet, spread up to the mid-shin proximally, usually symmetrical, and affect all sensory modality. Reduction of vibration perception examined by tuning fork, also penny break and fine touch and temperature sensation alternation. Decrease in vibration sense and absent ankle reflexes are usually the first feature of peripheral neuropathy. And this can examined and determined by 10-gram monofilament, this monofilament in which the patient unable to feel the sensation of 10-gram monofilament. Less often manifestation is allodynia, which or a frank pain can occur. Painful neuropathy occur only in 20% by sharp, stabbing, electrical shock-like, or burning in nature, and it affects sleep disturbance, mood disorder, and loss of quality of life. And also, peripheral neuropathy can affect the muscle, causing wasting of the intrinsic muscle of the foot with the clawing of the toe. Like this. This is how to examine by 10-gram monofilament assess peripheral neuropathy. This is a monofilament, and this is the area in which we should examine to illustrate is it normal or abnormal. How we can do 10-gram monofilament, and actually this is from this book, Best Practice Guideline Wound Management and in Diabetic Foot Ulcer. The sensory examination should be carried out in a quiet and relaxed setting. The patient should close their eye. The patient should sit supine with both feet with supine with both feet level. First, we should apply the 10-gram monofilament on the patient hand to detect the sensation, to educate him about this sensation. And then we should apply the monofilament perpendicular to the skin surface like this, with sufficient force to bend or buckle the monofilament like this. So we should compress it to let it to buckle or bend like this. And we will ask the patient whether they feel the pressure applied, yes or no. Whether they feel the pressure in the left foot or right foot. And we should apply the monofilament along the perimeter of, not on the ulcer side. Don't allow the monofilament to slide across the skin. The total duration of the approach, skin contact, and the removal of the monofilament should be around 2 seconds. We should apply the monofilament to each site 3 times, including at least 1 additional MOOC application. This is the size shown to identify 90% of the patient with abnormal monofilament test. This is the most important site. This is the blue one, and this brown site is other recommended site, and this site is optional force site. We should differentiate between large fiber affection and small fiber affection. Large fiber affection, this is presented by symptom numbness, tingling, and poor balance, and most examined clinically by affection of the ankle reflexes vibration perception, 10-gram monofilament. So 10-gram monofilament will examine a large fiber affection. A small fiber affection which is symptomatized by pain, burning, electrical shock, stabbing, and hyperalgesia and allodynia. And this should be examined by thermal, cold or hot discrimination, or pinprick sensation. Is it reduced or absent or normal? And let's go to some question from the official website. If we have type 2 diabetes mellitus, since long duration with sudden onset of a painful right eye, and actually this is a repeated question in the previous exam, with the dropping of her right eyelid, no double vision, no other neurological symptom. So sudden onset of painful right eye with the dropping of the right eye. And hemoglobin A1C is well controlled, MRI of the brain normal, and ask about long-term prognosis. What is the diagnosis here?
Mononeuritis.
Yes, mononeuritis. This is a third cranial nerve palsy, type of mononeuritis. What is the prognosis?
Very good prognosis.
Very good.
Prognosis.
Very good prognosis. So the patient, actually, she is likely to make a very good recovery. This is a very good prognosis, and the patient will be normal within few weeks, inshallah. So mononeuropathy, peripheral mononeuropathy, and the cranial mononeuropathy are not uncommon. This usually occurs spontaneously and not related to the control of hyperglycemia. A cranial mononeuropathy usually occurs suddenly with good prognosis. Palsy of the cranial nerve 3 and 6 are the most commonly, but still infrequent. In cranial 3 palsy, this is important, will spare pupillary response is usually. Spontaneous recovery is slow over a few months, and no treatment apart from symptomatic, which help like eye patch and so on. And actually, this image from the Oxford textbook mentioned manifestation of third cranial nerve palsy with ptosis of salmoplegia with mild dilatation, like this, of the pupil, and of course, complete recovery after few months. Another important disorder related to diabetes, peripheral neuropathy, is proximal motor neuropathy or diabetic amyotrophy. Diabetic amyotrophy is uncommon, mostly affecting men in their first with type 2 diabetes mellitus, presented with severe pain and paresthesia in the upper leg, and is felt as a deep aching pain, may be burning in nature, may awoke at night, and cause anorexia, result in marked cachexia, proximal muscle weakness and wasting of the quadriceps, and improvement is usually spontaneous over 3 to 4 months. Other causes should be excluded, like malignancy and lumbar disc disease. MRI of the lumbar sacral spine is recommended. The oral antidiabetic medication may play a part of a charge, so a conversion to insulin therapy is advised. 50% will recover fully. Let's go to another part from my session today, foot examination. Foot examination, as we mentioned previously, diabetes mellitus is the most common cause of non-traumatic lower limb amputation. So a foot examination is mandatory at diagnosis and every, at least yearly, in all asymptomatic patients. The gold standard examination would test vibration, fine touch with 10-gram monofilament, and reflexes. A neurosensiometer is, or biosensiometer is advanced tools not indicated except any specific situation if there is a significant risk of a neuropathic ulceration. الديفرنشال diagnosis of peripheral neuropathy is uremia, vitamin B deficiency, infection like HIV and leprosy, toxins like alcohol, mercury, drugs, chemotherapeutics, and malignancy. And actually, this slide summarizes all differential diagnosis of diabetic peripheral neuropathy. الهايبوثايروديزم can cause a picture like this: uremia, vasculitis, amyloidosis, infectious disease like hepatitis B, Lyme, HIV, inflammatory disease, in nutritional deficiency like vitamin B12, pyroxidine, thiamine, drugs like alcohol, amiodarone, chemotherapy, some of the heavy metal toxicity like arsenic, mercury, and hereditary or genetic disorder causing peripheral neuropathy. Of course, a treatment of neuropathy recommended and diabetic foot affection should be reviewed by podiatrist and ortho tests. And of course, asymptomatic patient, good glycemic control is mandatory. No drug available for the management of asymptomatic peripheral neuropathy. Actually, in painful diabetic peripheral neuropathy, we have a lot of medication, but asymptomatic diabetic peripheral neuropathy, no drugs are approved for this disorder. Painful diabetic neuropathy can be managed by 4 drugs: a tricyclic antidepressant like amitriptyline, duloxetine, which is a selective serotonin noradrenaline uptake inhibitor, and another drug is pregabalin, and another drug is gabapentin. So we have 4 first-line drug therapy approved by the NICE: a tricyclic antidepressant amitriptyline, duloxetine, gabapentin, and pregabalin. Which is the best? All are the same. Amitriptyline is used as a first-line therapy. Many patients fail to respond to them. Side effects are frequent, and it recommended dose 10 milligram to be increased to 25 milligram at night may be started, and the maximum recommended dose 75 milligram per day. Duloxetine in a dose of 60 milligram to 120 milligram per day. Don't forget the recommended dose. We should start within a week and lasting the full treatment period of 3 months. The main side effect is nausea. It is advisable to start with a low dose, 30 milligram per day, taken with food for a few days, then up titrate to 60 or 120. Gabapentin, which is anticonvulsant, is another first-line therapy, and the dose should be titrated to 100 milligram twice to 1,800 milligram per day. And the dose may be double, 3,600 milligram per day. Pregabalin is another effective first-line therapy. Starting dose is 75 milligram twice daily, and the recommended maintenance dose is 150 milligram twice daily, and the maximum dose 600 milligram per day. Another drug like carbamazepine, opiate, tramadol, oxycodone, intravenous lidocaine, topical capsaicin. This is not a first-line drug. If the patient is not improved in the first-line drug, we can shift to another drug from the first-line drug. If not improved, we can convert. Also, we shift to another first-line drug. And then we can combine, and then we can add other medication. Single application of topical capsaicin over 30 minutes can provide a 12-week of pain relief. Alpha-lipoic acid, which is antioxidant, was shown to be effective in a small meta-analysis and is used in Germany, Eastern Europe, and China, and don't choose this in the exam. So in NICE recommend, we have 4 options as the first-line therapy in the management of painful diabetic neuropathy: amitriptyline, duloxetine, gabapentin, pregabalin. If the initial treatment is not effective or is not tolerated, offer one of the remaining 3 drugs and consider switching again if the second and third drug tried are also not effective or not tolerated, and then combination therapy. And actually, this question from the study we are in, this is a 65-year-old male presented with 7-year diabetes mellitus, and he feels generally well in his glucose controlled, which is improved. He commencing insulin 4 months previously. Hemoglobin A1C is 7.4. There is a burning discomfort in both feet, more severe at night. He experienced only minimal relief with codamol and non-steroidal. There is a background retinopathy with a reduction of vibration sensation. Which of the following is the most appropriate therapeutic option for the managing the patient's symptoms? Capsaicin, citalopram, duloxetine, fluoxetine, paracetamol.
Duloxetine.
Yes, duloxetine. As we mentioned, we have only 4 options: amitriptyline, duloxetine, pregabalin, and gabapentin. So this is the pharmacological treatment of painful, don't forget, painful diabetic neuropathy. Tricyclic like amitriptyline from 25 to 75, but we should start by 10 milligram. Duloxetine 60 to 120, but we should start by 30 milligram initially. Gabapentin 300 to 3,600 milligram per day, or pregabalin 300 to 600 milligram, but we should start by 75 milligram twice daily. Tramadol, oxycodone, morphine, capsaicin, and intravenous lidocaine. And actually, this is from the American Academy of Neurology recommendation, the same dose, but mentioned here a duration by weeks. So duloxetine should be continued for at least 3 months. Gabapentin from 4 to 8 weeks. Pregabalin from 5 to 12 weeks. And amitriptyline for 6 weeks to be effective. So a duration of treatment is important, and a dose to start with, and the recommended effective dose is very important, because actually in our clinical practice we usually use a smaller dose like other than a recommended dose. Despite this treatment, however, many patients have suboptimal pain relief. So in non-pharmacological treatment like acupuncture, transcutaneous electrical nerve stimulation, electrical spinal cord stimulation may be used, but actually a NICE guideline did not recommend these maneuvers. General treatment for diabetic peripheral neuropathy, poor diabetic control appear to be associated with worsening neuropathy. Cardiovascular risk factor like hypertension, obesity, smoking, dyslipidemia, especially hypertriglyceridemia, are risk factor for peripheral neuropathy. Autonomic neuropathy, actually, the commonest effect of autonomic neuropathy is erectile dysfunction. 40% of males with diabetes will be presented with erectile dysfunction. Abnormal function tests can be expected in about 20 to 40% of general diabetic clinic population. And actually, Dr. Hussam Hosni bought this paper, and actually, I know that any paper start with B will be, I think, family physician, American Family Physician Journal. Yes, this is from the American Family Physician. This paper is a very important one, treating painful diabetic peripheral neuropathy update, but actually this paper is published since, I think, 2016. And Dr. Hussam also upload this paper, which I think the American Academy of Neurology. This is another paper related to painful diabetic peripheral neuropathy, practical guidance and challenge for clinical management. So this algorithm summarizes how to manage painful diabetic peripheral neuropathy. Risk factor and lifestyle modification is essential. Non-pharmacological treatment may be indicated but the most important is pregabalin or gabapentin, tricyclic, or duloxetine or venlafaxine. After that, if there is partial effective, we can add a second line treatment. Actually, this is not a nice recommendation. Nice recommend if partial effective or ineffective. If ineffective, we should switch to alternative monotherapy. If partial effective, we can add a second treatment, combination pharmacotherapy, الجابابنتين with tricyclic or SNRI, tricyclic with gabapentin, SNRI with gabapentin. So all of them is gabapentin, gabapentinoid, pregabalin or gabapentin plus amitriptyline or duloxetine. If intolerable, we should switch to alternative. If inadequate pain control, we can add a third line treatment like capsaicin, lidocaine, or tramadol. If inadequate pain control, we should specialize in pain surface treatment, spinal cord stimulation, or lidocaine stimulation. Thanks, Dr. Hussam, for this paper.
Dr. Khalid.
Yes, Dr. Hussam.
Can I give a comment?
Yes, yes, of course, Dr. Hussam. Yes, you are welcome.
Thank you. Yesterday, I was in a lecture about painful diabetic neuropathy. From reading the guidelines, I concluded that all guidelines I will mention ADA, American Association of Clinical Endocrinology, nice guidelines. Dr. Khalid.
Yes, you can continue, Dr. Hussam.
Sorry, 5 guidelines recommend for first line therapy of treatment of painful diabetic neuropathy. American Association of Clinical Endocrinology, NICE, and the ADA, and American Academy of Neurology and Dutch guidelines recommend that 4 classes are first guidelines or first line of treatment. Which is SNRI as duloxetine or gabapentoid, which are gabapentin or pregabalin, and tricyclic antidepressant, which is amitriptyline. Then they put second guidelines as anticonvulsant as carbamazepine, then non-pharmacological treatment, then third line, which is added recently, spinal cord stimulation or lidocaine infusion. Except Diabetes Canada, which is put pregabalin only is the first line, then the 3 options as a gabapentin or tricyclic antidepressant or duloxetine, SNRIs are second line of treatment. So which is, in my opinion, very nice conclusion. 5 guidelines recommend first line of treatment for group are equal others, except Diabetes Canada, which is recommend only first line is pregabalin, then other options.
Thanks, Dr. Hussam. Thanks. Actually, the voice is interrupted, Dr. Hussam. So, as you mentioned, actually, 4 drugs can be used as first line therapy, but don't forget that in NICE, we should follow NICE recommendation. And actually, pregabalin in our country in Egypt is not available. It is jadwal, so it is not available in wide scale. Let's continue autonomic neuropathy, and actually autonomic neuropathy, it may be cardiac autonomic neuropathy or gastrointestinal autonomic neuropathy causing gastroparesis, diarrhea, or constipation, and bladder hypomotility, erectile dysfunction, gustatory sweating, and reduced peripheral sweating. So, autonomic neuropathy may be presented with erectile dysfunction, posture hypotension, resting tachycardia, in which the patient presents with fixed heart rate or loss of sinus arrhythmia in up to 20%, gustatory sweating, in which the patient will be present with face sweating after tasting some food or specific food, delayed gastric emptying causing nausea and vomiting and abdominal fullness, constipation or diarrhea, urinary irritation or overflow incontinence, anhydrosis, in which the patient presents with absent sweating on the feet, is especially problematic, causing increased risk of ulcers, abnormal pupillary reflexes. The assessment is very difficult actually in a clinical scenario, except the autonomic posture hypotension, but autonomic neuropathy can be suspected if we check, for example, posture hypotension, lying and standing blood pressure. Usually less than 10 millimeter mercury drop, or if more than 20 millimeter mercury in the systolic, this is abnormal. This is a diagnostic for posture hypotension. Other less commonly performed test is sinus arrhythmia. If it lost, it will be diagnosed for autonomic neuropathy by measuring inspiratory and expiratory heart rate after 5 seconds of each. It is normally more than 15 beats per minute is normal, but if less than 10 beats per minute, this will be abnormal. And another one is loss of the heart rate response to Valsalva maneuver, and also blood pressure response to sustained hand grip. This is actually a sophisticated maneuver for diagnosis of autonomic peripheral neuropathy, and actually in the clinical exam is very difficult to know this. But actually, this table from the Oxford book summarizes all tests used for the assessment of autonomic neuropathy. The heart rate test, heart rate response to deep breathing, heart rate response to Valsalva maneuver, blood pressure measuring, blood pressure response to sustained hand grip, what is the normal and what is the borderline and what is the abnormal, and how to calculate it in this situation. Gastroparesis can be diagnosed by radioisotope test meal, which can identify delayed gastric emptying. And of course, blood glucose should be less than 10 to do this radioisotope scanning, as hyperglycemia will exacerbate a delayed gastric emptying. How to treat? This is based on specific symptoms and is usually symptomatic only. Posture hypotension can be treated by stopping drugs that can cause hypotension, like the beta blocker, the anti-anginal agent, tricyclic antidepressant. Increase its sodium intake up to 10 grams per day, and the fluid intake to 2.5 liters per day. Raising of the head of the bed by 10 to 20 degrees. Drinking 500 ml of water before or with meal will decrease the risk of posture hypotension. Using a custom fitted elastic stocking. Pharmacological treatment like fludrocortisone starting at 100 microgram per day. The potassium supplementation may be required. In severe cases, we can use alpha-1 adrenergic receptor agonist like midodrine, sympathomimetic ephedrine, and we can use octreotide or erythropoietin. This is how to manage posture hypotension as autonomic neuropathy. Erectile dysfunction, we should diagnose it, and we should put in our mind libido is not normally affected, and the pain is also unusual. So if there is low libido or pain, we should refer to urologist. So look for hypogonadism and Peyronie's disease. We have a lot of drugs that exacerbate erectile dysfunction, like thiazide, beta blocker, alcoholics, tobacco, cannabis, and stress. we should search for underlying disorder by doing prolactin, testosterone, and gonadotrophin, because if there is underlying disorder, hypogonadotrophic hypogonadism, we should treat it initially. Then a therapy for erectile dysfunction, we should start by phosphodiesterase 5 inhibitor like sildenafil, tadalafil, vardenafil, and most of them should be taken 30 to 60 minutes before intercourse, although daily dose of tadalafil is also approved. The second line is intraurethral alprostadil, then intracavernous alprostadil, then a vacuum device. And in each exam, they will ask a question related to how to manage erectile dysfunction. The first line is phosphodiesterase inhibitor, intraurethral alprostadil, intracavernous alprostadil, but don't forget that if the patient have some sort of bleeding disorder, intracavernous alprostadil is a contraindicated. And the last option is vacuum device and surgical procedure. None of these are ideal. Sildenafil, although an oral therapy, is effective in only 60%. Contraindicated in severe heart disease and those on nitrate. Don't forget this. Gastroparesis also is a repeated question in the final exam. We should treat by optimization of the glycemic control, stopping drugs that delay the gastric emptying like GLP-1 receptor analog, calcium channel blocker, anticholinergic drug, anti-emetic in the form of metoclopramide and domperidone. Domperidone is the most studied drug. But in the final exam, usually in combination with metoclopramide with cyclizine, usually the best option. Erythromycin, which may enhance the activity of the gut peptide motilene, can be used. So in the final exam, if you find combination metoclopramide and cyclizine, please choose it. If you find erythromycin like cyclizine or metoclopramide, we can choose it. Gastric electrical stimulation pacing is the last option for the treatment. Don't choose a domperidone except if they mention the most studied drug. Domperidone can cause a prolongation of the QT interval, so it requires specialist approval. A severe gastroparesis causing recurrent vomiting is associated with dehydration, so the patient required to be admitted and adequately hydrated with intravenous fluid. Blood sugar should be stabilized by intravenous insulin with antiemetics. Autonomic diarrhea, actual diarrhea which tend to be worse at night, can be alternatively with constipation. Diarrhea associated with bacterial overgrowth, so can be treated with doxycycline, erythromycin, tetracycline. Bile acid malabsorption like cholestyramine use, but the most important drug is lopramide and codeine phosphate if available. Refractory diarrhea can be managed by somatostatin octreotide, alpha-2 adrenergic receptor agonist clonidine, and of course octreotide suppress gastric motility and inhibit the release of motiline, serotonin, and gastrin. A neuropathic bladder is a rare complication of autonomic neuropathy, causing hesitancy of micturition, increased frequency of micturition, urinary irritation associated with overflow incontinence. Of course, the patient is prone to urinary tract infection, and the treatment maneuver include mechanical method of bladder emptying. Anticholinesterase drug such as neostigmine or pyridostigmine can be used and helpful. Long-term indwelling catheter can be used. Anhydrosis, which present with dry feet, can cause cracks in the skin, and in this situation, emollients cream may help prevent this. Gustatory sweating, which is manifested by increased sweating, usually affecting the face, and often brought about by eating gustatory sweating or what is known as gustatory sweating by specific foods. Treated by oral anticholinergic agent like oxybutynin or clonidine, and systemic side effects have led to investigation of non-systemic approach. Botulinum toxin can be used in some situations. In diabetic food. Of course, as we mentioned, diabetic foot problem are a leading cause of morbidity and mortality. Risk factor for foot ulcer development, several factors predisposed to ulcer formation, and we should classify our patient into at risk of development of foot ulcer if some of these features are presented. In neuropathy and sensory neuropathy is one of the most important parameters that increase the risk of foot ulcer. Reduced awareness of pain and trauma, and this should be examined initially by 10-gram monofilament. If abnormal, we should search for do another maneuver. Motor neuropathy and autonomic neuropathy is another cause. Peripheral vascular disease is a very important factor for development of diabetic ulcer. Microvascular circulatory disease, we should examine peripheral pulses and consider Doppler study if abnormal, and if peripheral pulses are abnormal, we should refer to vascular surgery. Abnormal pulses or peripheral vascular disease should be put in our mind in each patient presented with normal peripheral pulse. The previous ulceration is the most important predisposing factor to development of a new ulcer. Renal impairment also is another factor. The duration of diabetes, increased age, other microvascular complication is a risk factor. So this slide summarizes what is known as a critical limb ischemia. A risk factor for development of a critical limb ischemia, diabetes will increase the risk 4 times. Smoking will increase the risk 3 times. Abnormal ankle brachial pressure index will increase 3 times. If the age is more than 65, will increase double. Dyslipidemia will increase the double. Ankle brachial index, if less than 0.7, will increase to be double. This image actually is one of the most important images in the final exam. All the previous exam will be present this image except the previous June 2024. About 10 years ago, each year you will find image like this X-ray of the foot and ask about a specific bone or joint. But actually in the June 2024, no, this image in the exam. But don't forget, I expect that in the next SC exam and European board, you will find this X-ray again. So don't forget that. Try to memorize each bone and each joint between 2 bones. So don't forget that. This image is important. This is the tibia, and in the front of the tibia there is a talus bone, and in the front of the talus bone there is a navicular bone, then 3 cuneiform bone, and then a metatarsal bone. In the front of the fibula there is a calcaneus, which is heel bone. Calcaneus in the front is a cuboid, calcaneus C, cuboid C, and in the front of them is the metatarsal bone. So we have calcaneus, talus, navicular, cuboid. Cuboid in the front of the calcaneus. Here, talus, navicular, and in the front of them there is a 3 cuneiform bone and then a metatarsal bone. And don't forget that joints is important in between them. And actually joint is usually can be determined by the both joints, both bones. And actually this question from the Atoll book, and the question asked about Which of the following number correctly identify a navicular bone of the foot? Which is navicular bone?
Number 3.
Yes, this is number 3. Yes. Yes, you are right. So this image describes this bone in navicular. This is a navicular. Number 3. Number 1 and 5 and 2, this is cuneiform. And number 4 is calcaneus, and the front of the calcaneus is a cuboid. Number 2 is a cuboid. Number 4 is calcaneus. Yes. In foot ulcer, actually in the UK, the prevalence of foot ulcer in diabetes is about 5 to 10%. And actually, we have a clinical feature of diabetic feet. In neuropathic foot, warm, dry skin, palpable foot pulse, no discomfort with ulcer, callus formation. Ischemic feet usually is cold or cool, atrophic, often hairless, no palpable foot pulses, more often tender and painful. There is a claudication and rest pain, skin pinches on the elevation, and redness on dependency. And this image summarizes the difference between a neuropathic foot and ischemic foot. This is ischemic gangrene, and this is ischemia of neuropathic foot. Neuropathic foot, if there is infection, will be presented like this, and ischemic foot, if there is an infection, will be presented like this. This is a neuropathic foot ulcer, and this form of ischemic foot. And of course, we have a different classification for diabetic foot lesion. One of them is Wagner classification. Wagner classification classifies the foot ulcer into 5 grades. Grade 0 in the patient is diabetic with just a high risk foot, no ulcer is presented. Grade 1, there is a superficial ulcer. Grade 2, there is a deep ulcer with or without cellulitis, but no abscess or pore formation. Grade 3, deep ulcer with bone involvement or abscess formation. Grade 4, localized gangrene affected 2 for foot and heel, and grade 5 in which gangrene of the whole foot. And this is another image for Wagner classification, grade 1, grade 2, grade 3, 2 and 3 and 4 and 5 by image. And another classification, and this is a recommended one by NICE, is SIN-BAD classification of diabetic foot. SIN-BAD, SIN site, I for ischemia, N for neuropathy, B for bacterial affection, A for area, D for depth. And we have a specific scoring system. The site, is it for foot or mid foot or hind foot, will take 1 score. Ischemia, if blood flow intact 0 or absent pulses, it will take 1 point. Neuropathy, sensation intact 0, impaired sensation 1. In bacterial infection, if none, 0. If clinical sign of infection, 1. The area, if less than 1 centimeter, will take 0 score. If more than 1 centimeter, it will take 1 point. In depth, if superficial, 0. If tendon or bone, it will take 1. And actually, this scoring system is recommended, and of course, with higher score will be more diabetic foot lesion. The management of foot and diabetes is a very important, and we should classify our patient into each patient on at risk feet with no current ulceration. We should treat existing ulcer. We should treat infection. We should treat vascular insufficiency if presented. At risk feet with no current ulceration, the patient should be provided with advice and education. We should advise about nail care, hygiene, and footwear. We should educate and about importance of daily examination of the feet by the patient, and we should avoid barefoot walking. We should do regular podiatry review, and we should advise if we have bespoke footwear would be beneficial in preventing future ulceration. And actually, this is the area in which the area at risk of diabetic foot ulcer. This is the area which should be examined carefully because this is area of increase in diabetic foot ulcer. How we treat irregular existing ulcer? Regular debridement of callus and dead tissue, pressure offloading and reduction of the trauma is the most important step in the management of any diabetic foot ulcer. Regular wound review and dressing, optimizing glycemia, reduction of the edema to aid healing, early referral to multidisciplinary team for more severe cases is essential. The treating of infection is essential, and we should be a high index of suspicious with regard to infection when managing diabetic foot ulcer. If infection is suspected, we should give and prompt action in the close monitoring. Tissue sample should be taken, microbiological testing. If tissue sample are not possible, a swab can be taken before starting antibiotic, but should not delay to start therapy. We should exclude osteomyelitis by X-ray and MRI. Deep or chronic wound, or if there is ability to probe to the bone, osteomyelitis should be suspected. We should do X-ray as initial imaging modality. If normal, we can do MRI. Can be useful in confirming a clinical guidance. The antibiotic choice should be guided by local prescribing guidelines. We should treat vascular insufficiency. We should consider coexisting vascular disease because 70 to 95% of limb salvage rate often acuted if we refer the patient to a neurovascular surgeon promptly. Charcot foot. In each exam, you will see two questions related to the Charcot foot. Charcot foot is a rare complication of diabetes. If you see X-ray in an exam related to diabetic patient, diabetic foot, this is usually Charcot foot, except if they ask about the bone or the joint. If any X-ray in the exam, it is foot X-ray, it is usually Charcot foot. 10% of the case load of specialist diabetic foot clamp. The pathogenesis is unclear. It may be related to the blood flow increase, causing sympathetic nerve loss, causing osteoclast activity and bone turnover to increase, so making the bone of the foot more susceptible to the damage. It clinically presented with red, hot, swollen foot with history of trauma, minor trauma, pain, plus or minus pain, plus or minus deformity. Peripheral pulses are invariable. Presented, peripheral neuropathy is evident clinically. Differential diagnosis, we should differentiate, is it cellulitis, gout, DVT, and soft tissue. But in the final exam, this usually Charcot. If you see image like this is a Charcot. The plain radiograph may be normal initially, later show fracture with osteolysis and joint reorganization with subluxation of the metatarso-pharyngeal joint and dislocation. And we can classify it into two classical presentation: rocker bottom deformity and medial convexity due to the displacement of talano-navicular joint. So we have two different forms: rocker bottom deformity and medial convexity due to the displacement of specific joint. So this image from the William textbook showing a bone fragmentation, bony consolidation with osteosclerosis, with fusion of the joint, with gapping, with pain, welling. This is a Charcot neuroarthropathy. And we should differentiate between two different case scenarios in the final exam. Active Charcot versus osteomyelitis. The position, the site of the lesion is very, very important to differentiate. In osteomyelitis, usually in the forefoot or hind foot, in area of the calcaneus, but in Charcot, usually in the mid foot. In osteomyelitis, hot red foot with ulcer, Charcot, hot red foot without ulcer. The X-ray for osteomyelitis usually normal, and also for the Charcot will be normal initially. The MRI can differentiate in the osteomyelitis marrow edema in the forefoot and hind foot. Here's the ulcer, but the Charcot marrow edema in the mid-foot subchondral. So the mid-foot Charcot, the hind foot, and the forefoot is osteomyelitis. The management is very, very important. Total contact cost. Once you suspect Charcot, please choose in the final exam total contact cost. The treatment of the condition should be managed under the care of the foot MDT. Active Charcot is suspected, urgent onward referral should be made. The aim of the treatment is immobilization of the foot by total contact cost to prevent or reduce joint destruction and deformity. Below knee, post or pneumatic boot for at least 2-3 months. May need to continue for 12 to 18 months. The patient is likely to require bespoke footwear. And actually, once you see this image in the final exam, this is a Charcot. I don't know what is the lesion. This is a Charcot. So a chronic Charcot foot demonstrating a previous amputation of the 3 digit with vascular calcification. So if you see question like this, a patient with a plantar foot ulcer of 3 months in duration with right first metatarsal head, 10-year history of diabetes mellitus, and the ulcer is 3 by 2 centimeter area and the depth is 4 millimeter, clean, granulating, strong palpable pedal pulse, sensory neuropathy in both feet. This is a Charcot. What is the most effective intervention? Total contact cost. Ignore other option. Total contact cost. So what you need to know, diabetic foot can be prevented by good glycemic control, regular foot assessment, appropriate footwear, patient education, and early referral for a pre-ulceration lesion. We should examine the feet of the people with diabetes for any lesion and screen for peripheral neuropathy and peripheral arterial disease. Refer patient with foot ulceration and sign infection, sepsis, or ischemia immediately to specialized diabetic foot center for surgical care and revascularization and rehabilitation. And don't forget that this is a tips on the foot care for people with diabetes mellitus. We should inspect both feet daily. We should wash the feet daily with water at room temperature. We should use lubricating oil or cream for a dry scan. We should cut nails straight across. Don't remove corns and callus using a chemical agent. Always wear socks. Avoid walking barefoot. We should ensure a qualified healthcare provider examines your feet regularly. We should notify the healthcare provider at once if a blister, cut, scratch, or sore develops. This is a mandatory and this is essential to avoid the foot ulcer. And actually, Dr. Hissam Hosni, what this, I think this is the reference I already used for this is a diabetic neuropathy recommendation by American Diabetes Association recommendation. And actually, this is the offloading footwear used for the management. If we have ulcer in this position, we should do offloading. So by using this foot like this, and if the ulcer present in the heel, we can use a footwear like this. This is another very common image in the final exam. You usually put this image, and actually I put this because it is a repeated. This is a necrobiosis lipidica diabetic. This is a very, very important image presented in most of the previous exam record. And this is another image for limited joint motility arthropathy, or what is known as a prayer sign or Garrett's pain. Macrovascular disease, I just have to cover hypertension, dyslipidemia, and macrovascular disease in a diabetic patient in a brief. Of course, macrovascular complications are increased in a patient with diabetes mellitus. The prevalence and the incidence relate to the age and gender ethnicity. Vascular complication account for around 3/4 of deaths in both type 1 and type 2. The peripheral vascular disease occurring up to 10% of the patient, 15-fold a greater risk of needing of non-traumatic amputation. Thromboembolic cerebrovascular event increase the risk of MI is double or quadruple time in the individual with diabetes mellitus. The secondary prevention is essential by stopping the smoking, control of hypertension, blood pressure. Lipid-lowering drugs is essential. Early control of blood glucose, and aspirin is not recommended nowadays for primary prevention. Don't forget that aspirin previously is recommended for primary prevention, but nowadays is not recommended for diabetics as a primary prevention. If the patient has ischemic heart disease, we can prescribe aspirin. If the patient has peripheral arterial disease, we can give aspirin, but otherwise is not recommended as a primary prevention. And of course, the pathogenesis of macrovascular complication is glycemic control has a role in hypertension, dyslipidemia, and obesity, insulin resistance, as I mentioned, altered coagulability. All of these factors can cause and can affect the macrovascular complication. And of course, the most important item to be used nowadays is statin. Lipid abnormality in patients with diabetes is important, and it is associated with the greater risk of macrovascular disease. Usual finding in diabetic are increased triglyceride, which containing lipoprotein, a chylomicron, and very low density lipoprotein. And of course, the HDL cholesterol will be decreased. Low density lipoprotein particles will be increased mildly with a greater tendency to oxidative damage. Screening for secondary cause of dyslipidemia is essential, like hypothyroidism, liver disease, nephrotic syndrome, alcoholics. And of course, the management of dyslipidemia should start by dietary advice, a healthy diet. We should stop the smoking, we should reduce the weight, and increase the physical activity. Don't forget that lipid lowering therapy, we should, the European Society of Cardiology and the ESD classify patients into 3 categories: moderate risk, high risk, very high risk. And of course, the target of the LDL cholesterol is different from this category. Moderate risk in a patient with type 1 diabetes mellitus less than 35 years, or type 2 diabetes mellitus less than 50 years of old, with diabetes duration less than 10 years, and no other risk factor, not hypertensive, not smoker, not obese. The high risk in which the duration of diabetes more than 10 years, usually with additional risk factor, but no end organ damage. Very high risk, a patient with established cardiovascular disease, target organ damage, multiple risk factor, or diabetes duration more than 20 years. The treatment aims of lipid, total cholesterol less than 4, LDL in the moderate risk less than 2.5, high risk less than 1.8, very high risk less than 1.4, or at least 50% reduction from the baseline. HDL cholesterol is not very important, more than 1. It triglyceride less than 2.3. And don't forget that statin is the first line therapy. If not reach the target, we should add ezetimibe. If not reach the target, we can add PCSK9 inhibitor, which are currently reserved for high-risk resistant cases or patient with statin intolerance. And actually, Dr. Hissam Hosni uploaded the American Diabetes Association 2024 guideline for the management of retinopathy, neuropathy, and foot diabetic foot or neuropathy. The pharmacological intervention to increase the HDL cholesterol has not been shown to improve the clinical outcome in a lot of trials, so niacin is not recommended nowadays for increasing HDL cholesterol. Mixed dyslipidemia, we should consider fibrate or statin license for this indication. Fibrate, this is very important. Fibrate usually target triglyceride, will decrease the triglyceride by 30 to 40%. LDL cholesterol will be decreased by fenofibrate by less than 20%. Statin will reduce the triglyceride slightly by about 10% and will reduce the LDL cholesterol by 25 to 35% and up to 55%. So if there is increased level of the triglyceride, fenofibrate can be used. If we target the LDL, statin should be used. So in a diabetic patient, we should start with a statin, except very high triglyceride. Hypertension, of course, hypertension is twice as common in individuals with diabetes mellitus, and actually we have a lot of the targets of the blood pressure. In each year, the guideline recommend a different target, but the Euglycemic study suggests target blood pressure to be less than 140/80, except if there is end organ damage or microalbuminuria and so on. And type 1 diabetes mellitus hypertension is strongly associated with diabetic nephropathy and microalbuminuria. And type 2 diabetes mellitus hypertension is associated with insulin resistance and hyperinsulinemia. And it will increase its sympathetic nervous system activity. In management of hypertension is important, and NICE actually recommend blood pressure to be less than 140/80, except if the patient presents with diabetic complication, we should target blood pressure to be less than 130/80. And we should exclude other causes of hypertension like Cushing, acromegaly, chromocytoma. These three conditions can cause hypertension and hyperglycemia. General treatment of hypertension, we should modify other risk factors like obesity, salt intake. We should be reduced to be less than 6 grams per day or 5 grams per day. Reduce alcohol intake. Exercise 20 to 40 minutes of moderate exertion 3 to 5 times per week. In pharmacological therapy, as recommended by the NICE guideline, we should start by ACD approach. We should start with ACE in diabetics or ARBs. If the ACE is not tolerated, then we add in either C, calcium channel blocker, or D, thiazide diuretic. Alpha blocker, beta blocker, or further diuretic therapy then added if this failed to reduce blood pressure if we combine 3 ACD. So don't forget that NICE recommend ACE or ARBs as the first line therapy in the management of hypertension in diabetics. Then if not controlled, we can add calcium channel blocker or thiazide diuretic, and if not controlled, we can combine a triple therapy, ACE or ARBs, plus calcium plus thiazide diuretic, and if not controlled in this situation, we can add alpha blocker, beta blocker, or spironolactone. In the presence of microalbuminuria, ACE is the first line, or ARPs. In African or African Caribbean patient, ACE and beta blocker are less effective. So we can start with calcium. A diuretic may be needed to improve the efficacy of the ACE in this patient. A high dose of thiazide and beta blocker can in theory worsen diabetes control and exacerbate dyslipidemia. The SGLT2 inhibitor class of hypoglycemic agent have shown constant reduced blood pressure, as we know. In those with peripheral vascular disease, consider vasodilator like calcium channel blocker. In glycemic control to achieve hemoglobin A1C less than 6.5 or less with avoidance of hypoglycemia, we should strict blood pressure control to the target. Blood pressure less than 140/80 or less than 130/80 in a micro or macrovascular complication if presented. Dyslipidemia, total cholesterol should be less than 4, LDL less than 2, and of course triglyceride less than 2.3. The patient should be encouraged to lose weight with healthy diet and regular exercise. Aspirin is not recommended in primary prevention, for a primary prevention. Let's to finalize the last session in diabetes by this question. If we see question like this, a patient with type 1 diabetes mellitus with a dull ache in the right foot, no trauma to his foot, there is a worsening gustatory sweating with postural hypotension. The right foot was 3.2 centigrade, warmer than left foot. There is a difference between the right and the left foot temperature. X-ray of the foot calcified, blood vessel only, no bony abnormality. The MRI consistent with Charcot. What is the most appropriate system? Actually, they answered the question. They mentioned it is a Charcot joint. So, and this actually from the official website. Once you see Charcot, please choose total contact plus circles, immobilization. And don't forget that if you see immobilization in a question, and this is usually hypercalcemia due to the immobilization. If you see a patient with long duration of immobilization, this is usually causing hypercalcemia. If a question related to the parathyroid. This is another question from the exam lab. A right grade 2 and painful right foot. The patient is type 1. Recently screened had revealed some mild diabetic retinal change and peripheral neuropathy. There is a hot red right forefoot. Once you see forefoot, what is the lesion?
Osteomyelitis.
Once you see forefoot, hot red right forefoot, we should suspect osteomyelitis. So don't forget, this image actually is important. I would like to go to it again. This one, hot red foot and ulcer, forefoot and hind foot, this is osteomyelitis. Hot red foot, no ulcer, and mid foot, this is active Charcot. Another question, this is what? This X-ray, what is the abnormality here? I cannot know, I don't know. But the question asked about foot clinic tripped over his cat 1 week previously, combined an ache in his left foot since then. The patient already in a lot of drugs. Dorsalis pedis and posterior tibial pulses were easily palpable. The urine albumin character ratio is mildly elevated, and this is X-ray. As I mentioned previously, if we have some sort of foot pain and X-ray like this, and I don't know what is the pathology, it is usually Charcot. So the answer should be full contact plus sarcosis. And this is from the exam lab. Another question, A patient, 50 years old Asian woman, 18 years history of type 2 diabetes mellitus, discomfort, mild swelling in the left foot after dripping on a pavement. Already in the metformin glycoside by glitazone. There is a warm, slightly edematous over the dorsum but not discolored. The patient is afebrile. There is a foot pulses were pounding. Tender reflexes in the leg were absent and vibration perception diminished. Uric acid show protein +2, glucose +1. Leukocytic count is normal. Creat, hemoglobin A1C, X-ray, there is some calcification. Isotope scan, isotope uptake in the mid foot only. What is the most effective next step? Immobilization. Yes, you are right. Immobilization. Once you see mid foot, this is a Charcot, soil immobilization in a cast is the best option. Another question, type 2 diabetes mellitus with hypertension, with peripheral neuropathy, and there is a dull aching discomfort of the right foot. There is a pounding peripheral pulses. The pressure was 20 degrees centigrade on the left foot and 26 degrees centigrade on the right foot. There is a difference 6 centigrade. Which of the following is the most likely diagnosis of this lady? Absence of the right foot, Charcot neuroarthropathy, diabetic foot osteomyelitis, venous traumatic fracture. As you know, once you see foot abnormality, please choose Charcot neuropathy in the final exam. And this is a question from the toll book. This is a patient presented with 8 months history of excruciating pain in the feet, keeping him awake in the night. So this is actually a painful diabetic neuropathy. The patient started on a pregabalin tablet, 300 milligrams twice daily for over 6 months, did not feel to be beneficial for symptom relief. The patient is type 1 on basal bolus, and benign sensation by monofilament is reduced. Ureal creat is mildly elevated. Estimate GFR is mildly reduced. Hemoglobin A1C is mildly elevated. And the question asked regarding a nice guideline. Appropriate treatment option for the patient in the view of ongoing neuropathic pain. Increase pregabalin tablet. The patient already in 600 milligrams daily. Reduce pregabalin and give add tramadol. Start amitriptyline along with pregabalin. Switch to amitriptyline. Switch to tramadol. Which one?
Switch to amitriptyline.
Yes. If one drug from the first line therapy for a drug is not effective or not tolerated, we should switch. And if amitriptyline is not effective, we should switch to another drug. 5-year history of type 2 diabetes mellitus, worried about developing of foot ulcer. And the question asked about best predicts the development of foot ulcer in a patient with diabetes. Which one? Absent foot ulcer, pulse, absent sensation to monofilament, history of previous ulcer, inability to perform on foot care, vibration perception, threshold more than 25 voltage. Yes.
History of previous ulcer.
Yes, history of previous ulcer is the most predictor for development of future ulcer. Not absent sensation to monofilament. Absent sensation of monofilament is the first initial manifestation for diabetic peripheral neuropathy. But a foot ulcer, a previous foot ulcer, is the best marker for next future ulcer. Don't forget this. And actually, this question is repeated in the previous exam. In our exam in 2018, there is a question like this. A patient, 73-year-old male, attending diabetes clinic for 6 weeks. The ulcer, by ulcer on his right second metatarsal head, and receiving regular podiatry and offloading. What new feature in the appearance of his foot is most likely to suggest the need to start antibiotic? Increase in ulcer size, pain around ulcer, skin redness around ulcer, tracking sinus, ulcer improving to the bone. Suggest need to start antibiotic. What is the sign of inflammation? Yes, skin red. Yes, skin red. Sign of inflammation, skin red, not pain. Another question regarding differentiation between osteomyelitis. We have a type 2 diabetes mellitus patient presented by ulcer on the plantar aspect of the fifth left toe. The ulcer probed to bone, no sign of inflammation. There is a little improvement. And the patient concerned about possible osteomyelitis. We have a normal X-ray since 4 weeks. Previously had been normal. What is the most appropriate next step? As we mentioned, osteomyelitis mean two investigation, X-ray and MRI. Don't forget this. Osteomyelitis, if we suspect osteomyelitis, we have two imaging modality, X-ray and MRI. The X-ray since 4 weeks are normal. What is the best option here?
I think plain X-ray again.
Yes, we should repeat X-ray. X-ray since 4 weeks is not an indication of no osteomyelitis today. So we should repeat X-ray, and if X-ray is normal, in this situation we can do MRI of the foot as a next imaging model. Another question from the exam lab, and this is a type 2 diabetes mellitus presented with a 3-day history of an ulcer of the right second toe. Examination, the toe was red, swollen, and enlarged, and looked like so digit. The ulcer appeared superficial, so this is inflammation. X-ray of the right second toe, no sign of osteomyelitis. Culture from the debrided wound bed were taken and the result were awaited. What is the most appropriate type of antibiotic regimen to start empirically before the culture results are available?
Narrow spectrum for 6 weeks.
Yes. Don't forget that narrow spectrum for 6 weeks is the ideal option if we suspect infection in a diabetic patient. Narrow spectrum for 6 weeks, and actually this is another repeated question in the previous exam. Another question, a patient with infected ulcer measuring 2 by 1 centimeter over the right first metatarsal head with surrounding cellulitis. No previous history of diabetes mellitus. The temperature is 37.4. Blood pressure is elevated. The body mass index is obese. Random plasma glucose is elevated. Hemoglobin A1C is 81. What is the most appropriate treatment for this hyperglycemia? Recent onset hyperglycemia. Both insulin, exenatide, ecliclazide, metformin, sitagliptin.
I think insulin. Start insulin during this infection.
And insulin therapy is not indicated except if they mention it is a severe infection. If there is a manifestation of severe infection, otherwise we should start by ordinary drug, metformin, and if the patient is not controlled, sulfonylurea or DB4 inhibitor or pioglitazone. So in this situation, as mentioned, we should start by only metformin. Another repeated question, ask question about talonavicular joint. Talonavicular joint. Where is the talus and where is the navicular bone? You will find talonavicular joint. Which
number
one?
2.
Yes,
Number 2.
Number 2. This is a talus and this is a navicular bone. So this is a talonavicular joint. So don't forget this image is very important. So this is a navicular bone and this is a talus in between talonavicular joint. Another question relates to the clinical assessment of diabetic peripheral sensory neuropathy. a patient with a 3-year history of type 2 diabetes mellitus, hemoglobin A1C is 51.9. The main complaint at present is that persisting tingling and discomfort in her feet. How to assess tingling and discomfort? By which tool?
Loss of vibration is sensation is an early
Yes.
clinicals.
Yes. So a small fiber reduction by evaluation of thermal discrimination, while large fiber evaluation by vibration and perception, proprioception sensation. So a tuning fork sensation, loss of vibration, to assess a large fiber is the first initial examination in peripheral neuropathy. Large fiber affection by loss of vibration sensation is an early clinical feature determined by 128 tuning fork assessment. Another question, and once you see dorsalis pedis pulse is feebly palpable, what is the best next option? Once you see dorsalis pedis pulses is feebly palpable, is not palpable well, which of the following is the most appropriate step in the management? Yes, once you see dorsalis pedis pulse not palpable well, we should refer to vascular review. The last question in my session today from the study BRN, a 32-year history of type 1 diabetes mellitus and presented with persistent burning sensation. The patient has ongoing problem for the last 2 years, and the patient shown no symptomatic response to co-diamol and non-steroidal anti-inflammatory drug. There is a chronic suboptimal glucose control with a most recent hemoglobin A1C is 73.8 millimole per mole. Blood pressure is mildly elevated, body mass index is overweight, preserved dorsalis pedis pulse, and there is a reduced vibration and posterior tibial pulses are normal. Proprioception sensation are affected, along with biosensiometer reading is affected. What is the most appropriate therapeutic approach for this patient? Persistent burning sensation.
Duloxetine.
Yes, duloxetine. Yes, duloxetine. So don't forget that duloxetine, gabapentin, pregabalin, amitriptyline can be used as a first-line therapy. So duloxetine is the best option here, and actually this is the last question in my session today. Inshallah, in the next session, I will cover the previous exam recall June 2024, and actually this session will be after 2 weeks. In the next Friday, I will be in Thyro Alex, inshallah. I will do a talk about the thyroid and supplementation. So, inshallah, in the next session will be after 2 weeks. I will cover the previous exam recall. Actually, the previous exam recall is a very big file. Actually, I am just working on it since a few days. Actually, this contains just about 238 slides for a question only. So it will be a very big session, inshallah. I will do a lot of adding answers and doing comments about it, inshallah, after 2 weeks. Inshallah, I will work on this file within the next 2 weeks, inshallah, 2 weeks before the exam. So it will be after 2 weeks, inshallah. Today, inshallah, I will upload this session as a YouTube record, and inshallah PDF I will upload it immediately. واشوفكم على خير ان شاء الله after 2 weeks and to continue these sessions inshallah.
انت بخير ان شاء الله. Thank you very much. شكرا.
السلام عليكم يا دكتورة نيفين. صوتي واضح؟ الو. الو. طيب، ازاي ننزل البرنامج؟ احنا من خلال الملفات بتاعتنا بتاعت البلاي ليست. انا مش متأكد، اشوف البلاي ليست بتاعت. يبقى دي البلاي ليست مثلا بتاعت الريفيجن. يبقى ادي البرنامج محطوط هنا، ادي اللينك بتاعه كمثال. انا رايح اشوف اللينك بتاعه مكتوب هنا ايه. ادي البرنامج اللينك بتاعه، لينك فور ذا بروجرام. يبقى لو عملت كليك على اللينك ده راح يدخل على صفحة الجوجل، العنوان بتاعها اوكي فايرفوكس. وامشي مع الخطوات ان البرنامج رايح يتنزل على الجهاز بتاعي. يبقى كليك على البرنامج نفسه. انا عايز اعمل له داونلود، يبقى بالزرار اليمين. اشوف بالزرار اليمين في اوبشن، زرار اليمين مش جايب. يبقى اعمل حاجه داونلود اوبن. اشوف، اختار زرار الداونلود ده. هنا بيقول لي حجم الملف اكبر من 66، اقول له داونلود اني واي. هنا رايح يكمل معاك البرنامج، راح ينزل على بارتيشن معين على الجهاز بتاعي. يبقى ده لازم اعمل له داونلود على الجهاز بتاعي. البرنامج ده بيشتغل على نظام ويندوز فقط. يكمل بس نزيل الملف. كمل نزيل. يبقى بالزرار اليمين على اللينك ده وبختار شو ان فولد. يبقى هو الملف بتاعي اللي هو ده. انسخ الملف ده كنترول سي او كنترول اكس وحطيه على اي روت على الجهاز بتاعك، سواء الدي سواء الاي سواء الاف، اي بارتيشن. وليكن انا رايح احطه مثلا هنا على الاي. يبقى رايح احط الملف هنا. يبقى نسخته هنا عادي. بيقول لي موجود، بقول له حطه عادي نسخة تانية. واعمل له الملف ده، لازم اعمل له اكستراكت. يبقى بالزرار اليمين واعمل له اكستراكت هير، او اكستراكت الزهري اس اي. خلينا على الفولدر، يتعمل كفولدر. يبقى في الحالة دي راح منزل لي الملف كله على الفولدر ده. فين الفولدر اللي نزل هنا اللي هو ده؟ دبل كليك عليه راح هتلقي فيه سيت اب. لازم اشغل السيت اب ده في الاول. يبقى الخطوه الاولى اني بشغل السيت اب. دبل كليك عليه رايح يقول لي انزل البرنامج، رايح اقول له كمل وامشي معاه لحد ما يخلص ايه السيت اب، واعمل كليك هنا رايح ينزله لي. بعد ما يخلص السيت اب ده اكمل عليها. بعد ما يخلص السيت اب، خلص السيت اب وقال لي كومبليتد، اشغل الملف الاكسي ده. دبل كليك عليه. يبقى انا شغلت الملف، ادي اشتغل بالنسبه لي. بس هنا بيشترط عليا اني لازم اكتب باسورد هنا. الباسورد ده ما تكونش مكتوبه عندك. فالمطلوب منك راح هتبعتي لي اليونيك اي دي ده على الواتس، والاسم اي اسم مش مشكله. وانا رايح ابعت الباسورد دي. الباسورد بمجرد ما بتكتبيها هنا اوكي هيشتغل معاك البرنامج عادي. البرنامج ده انا ممكن ابحث منه، يعني مثلا هنا كمثال انا عايز الاسئله بتاعت ايه، بيست اوف 5 كتاب اتول مثلا. عايز لا الاسئله بتاعت ايه مصدر تاني مثلا ايه الاون اكزامينيشن مثلا ايه خلي اون اكزامينيشن، يبقى اون اكزامينيشن راح هتلقاه بريتش اللي هي الملف ده. انا عايز بتوع الثيرويد من اون اكزامينيشن، يبقى اختار الثيرويد من المنطقه كده، واشوف براحتي ايه ابدا السؤال ده صح ولا غلط، اختار اوبشن بالنسبه لي ايا كان الاوبشن واختار اوكي، هو رايح يقول لي الاجابه صح ولا لا، عايز اجرى الاكسبلانيشن وهكذا. اشوف السؤال اللي بعده، السؤال اللي بعده. وطبعا بعد شويه كده انا السؤال ده مثلا كان صعب بالنسبه لي، يبقى ممكن اعمل له ايه فلاج مثلا هنا، وممكن انا نفسي اختار ان السؤال ده صعب، فلاقي السؤال ده رايح احطه ايه صعب جدا، السؤال لا ده سهل، السؤال ده عايز يتعاد، يبقى انا ممكن لان بكره وبعده الاوبشنز دي ممكن اختارها، يعني ممكن اختار من هنا ايه مثلا يفلتر لي الاسئله، مثلا انا رايح اختار الاسئله كل الاسئله بتاعت الثيرويد، بس انا اللي حاططها انها صعبه فيري هورد، يبقى دي الاسئله اللي انا معلمها فيري هورد، بحيث في اي وقت تبع الثيرويد، بحيث في اي وقت انا عايز اراجع الاسئله الصعبه، بس الاسئله اللي انا غلطت فيها، الاسئله اللي انا ما جاوبتهاش، ده كله هتلقيه من خلال الاوبشنز دي. ولو في اي احتياجات معاكم في اي وقت. انا مع يا دكتوره نيفين، انت معايا؟ انتبهت للقصه من الاول ولا لا؟
معلش انا لسه دخلت من فاتني الاول يا دكتور خالد، بعد اذن
اصل
حضرتك.
انا دخلت لقيت حد دخل معاي دكتوره، فانا ظنيتك انت، عشان كده انا حتى حاولت اتكلم معاكي ما ردتيش، فقلت خلاص اشرحه وكده. بص اهم من الاول القصه دي مره تانية من الاول.
تمام، ربنا يبارك في حضرتك.
بص احنا كده او كده ادي اللينك اللي بتنزلي من خلال البرنامج صح كده، اللينك اللي هو
تمام، انا
الملف
عندي اللينك
الريفيجن،
بس.
معاك اللينك ده كليك على اللينك ده اوتوماتيك رايح يشغل لي الجوجل درايف دي، مظبوط كده.
تمام.
انا اختار هنا داونلود، يبقى انا بختار من الزرار اللي من فوق ده داونلود، ان عشان ينزل لي الملف ده على الجهاز بتاعي، فانا بختار داونلود، فهنا رايح يجيب لي رساله ان الملف ده حجمه اكتر من 66 ميجا، فانت متاكد عايز تكمل، رايح اقول له اوكي كونتينيو داونلود اني واي، رايح ينزل لي الملف على الجهاز بتاعي، ادي نزل لي الملف هنا، اخليه يكملها مثلا، يبقى بعد ما بيكمل لي نزيل الملف كده راح هتلقي الملف اتحط عندك، طبعا انا عشان ما كملتوش خليه يكملها. يبقى بعد ما بيكمل الخطوه دي خلاص هو نزل لي الملف على الجهاز بتاعي. كمل نزل الملف خلاص، رايح افتح الملف، بس الملف ده اتحط في فولدر معين، اتحط على ماي دوكيومنتس، انسخ الملف ده واحطه على اي روت، اي فولدر باي مجلد جديد، مثلا انا حطيته هنا في الجي، نسخته وكده، يبقى ادي الملف، بس الملف ده مضغوط بصيغه رير، فلازم اعمل اكستراكت للمحتوى بتاعه على الروت، يبقى انا بالزرار اليمين وبختار اكستراكت تو الظهري الفولدر ده. لو انا ما عنديش برنامج فك الضغط ده لازم انزل برنامج فك ضغط باي طريقه، يبقى البرنامج اللي نهايته رير ده ملف مضغوط لازم افك ضغط، انا رايح اعمل له اكستراكت هير. بعد ما فك الضغط هو عمل لي الفولدر ده، فين الفولدر اللي هو الظهر ده واحد فيهم الظهري، اللي هو عمل لي واقف، اعمله تاني عمله لي تحتيه على طول اللي هو الفولدر ده، بس الفولدر ده المفروض بيبقى اسمه كده الظهري السي اندوكرايولوجي 2022، دبل كليك عليه هتدخلي الفولدر، راح هتلقي ملفات، اعملي سيت اب في الاول، لازم دي الخطوه دي اساسيه، سيت اب، بيقول لي اكمل، اوكي كمل، اوكي، ورايح اختار هنا كليك الاوبشن ده عشان يكمل لي فك الضغط بتاعه. بعد ما يخلص مرحله فك الضغط دي اشغل الملف على طول. يبقى الخطوه دي مهمه عشان اشغل الملف بتاعي. هننتظر لحد ما يخلص. بمجرد ما يخلص هتلقي الفولدر ده خلاص، يبقى اشغله من خلال الملف ده الظهر اي سي اندوكراينولوجي فيرجن 1 اكس سي. دبل كليك عليه هيشتغل معايا الملف. بس الملف ده عشان يشتغل محتاج باسورد. الباسورد دي رايحه ابعتها لك بعد ما تبعتي لي الرقم ده، يعني الرقم اللي من فوق ده ابعته لي من خلال الواتس. يبقى الملف الرقم ده خاص بكل جهاز كمبيوتر مختلف. مجرد بتنسخيه وتبعته لي على الواتس رايح ابعت لك الباسورد اللي تشغل البرنامج. اوكي خلاص. يبقى البرنامج ومش محتاجه تكتبيها الا مره واحده، يعني في اي وقت انا رايح اشغله هتلقي الباسورد مسجله.
تمام. هو انا كده فتحت الخطوه دي، كنت حضرتك قلت لي قبل كده، لكن لما جيت اشغل مش عارفه بقى اتحرك. يعني كل الخطوات اللي حضرتك قلتها دي انا عملتها.
الجهاز اللي عندك شغال على كده على الكمبيوتر ولا لا؟
هو فتح بس ما بعرفش بقى اشتغل اقلب والحاجات دي. يعني انا اوريدي كنت بعت لحضرتك وحضرتك بعت لي الباسورد.
طيب يبقى انت كده او كده عديت الخطوه دي. طيب
تمام.
اعملي لي شير للشاشه بتاعتك. هتعرفي تعملي شير؟
هو انا فاتحاه على اللاب وفاتحه الزوم على الواتس.
طب
طب
بصي، انت شغلت البرنامج ولا ما شغلتيش؟ اصلا ما اعرفش.
هو شغال عندي، بس انا بقى كنت عايزه الحتت اللي حضرتك بتقولي نقلب منها وكده. دي انا يعني انا بيجي لي اول سؤال وما بعرفش اقلب بقى.
طب ثانيه واحده ده. ادي البرنامج عندي صح؟
تمام.
نفس الشاشه دي ولا شاشه مختلفه؟
لا لا، هي.
لو عايزه تقلبي ادي في زرار اسمه بريفيوس كويستشن نيكست كويستشن. البانل اللي ناحيه اليمين دي كلها هي بتاعت التحكم.
ايوه تمام، هي دي بقى اللي انا ما كنتش فاهماها يعني.
الخانه مثلا الخانه الاولى كده اهم خطوه هي السورس. السورس ده
اوكي.
انهي مصدر انت عايزه؟ انهي مصدر؟ اون اكزامينيشن ولا كتاب اتول ولا ايساب ولا انهي مصدر؟ دي اكزام لاب كمثال. خلينا في اكزام لاب، انا رايح اختار اكزام لاب. يبقى هنا الليسته دي معروض فيها اسئله اكزام لاب كلها، وكاتب لي من تحت ده السؤال رقم 1 وهم 200 سؤال. عايزه تروحي لاي سؤال بكليك هنا عادي. يبقى ده السؤال ده سؤال ده، تنزلي بالليسته دي تروحي لاي سؤال. لا افرض انا عايز اسئله الثيرويد بس، يبقى من الشاشه دي ادي السب كاتيجوري. اختار هنا ايه؟ السب كاتيجوري. يبقى على كده رايح يعرض لي اسئله الجونات كمثال من اكزام لاب. يبقى دول كام سؤال؟ 26 سؤال. عايزه السؤال ده، جريت السؤال ده والاجابه بتاعته، اختار ادي هيماتوكريت وادي تعلقي وتكبري. يعني ايه في النهايه راح تتحكمي في السؤال بالطريقه عايزه تكبري الصوره المعروضه كده. السؤال ده صعب ولا سهل؟ كمثال السؤال ده صعب، فانا ممكن احط السؤال ده كويستشن رانك اخليها ايه؟ السؤال ده صعب بالنسبه لي تو هارد كمثال، بحيث بكره وبعده لو عايز الاسئله اللي انا عاملينها رانك تو هارد يعرضليش الا الاسئله اللي انا مختارها تو هارد، بحيث اعيدها مره ثانيه صعوبه اكررها، اعيدها مره اثنين ثلاثه وهكذا. وممكن اعمل فلاج على السؤال ده بحيث في اي وقت مثلا انا طلعت من البرنامج طلعت منه خالص وشغلته تاني، اقول له اعرض لي الاسئله اللي انا عامل لها فلاج، او الاسئله اللي انا مختارها تو هارد، او الاسئله اللي انا عامل لها مواصفه معينه. يبقى انا رايح اقول له شايفه هنا في الفلاج، اقول له الاسئله اللي معمول لها فلاج بس. يبقى هنا مش رايح يعرض لي الا ال 39 سؤال لان انا مختار اسئله قبل كده انا عامل لها فلاج، فتلقي مش عرض الا الاسئله اللي معمول لها فلاج بس. لا، الاسئله اللي عاملين لها فلاج ومصدرها ستادي بي ار ان مثلا او اون اكزامينيشن يبقى في 5 اسئله وهكذا. اتفقنا؟
تمام يا دكتور. ربنا
سهله.
يبارك في حضرتك.
هتلغي في اختيارات كتير في البرنامج، ان يعمل اسئله عشوائيه، ان ممكن يعمل اكزام سيميوليتور، ان هو اوتوماتيك يعمل تأليفة الامتحان اللي هو 200 سؤال، 28 سؤال دايابيتس دايجنوزس، 12 سؤال اميرجنسي، 28 سؤال كومبليكيشن، يعني كل اسئله الدايابيتس، يعني عدد من الاسئله مشابه لعدد اسئله الامتحان. بس ما تركزيش في القصات، اللي يهمني ركزي في الكاتيجوري والتقسيمه بتاعتها، الصعوبه والسهوله بتاعتها. ماشي. ولو
تمام،
في اي
شكرا
حاجه،
لحضرتك.
في حد،
شكرا.
الدكتوره تيسير سالت ممكن ترسل لي رابط تحميل البرنامج. المفروض لو عند حضرتك يا دكتوره تيسير اللي هو الملف بتاع البلاي ليست بتاعت الريفيجن دي، موجود الرابط بتاعها في الصفحه دي، الصفحه رقم 4، هو ده الرابط بتاع البرنامج. كليك عليه زي ما اتفقنا واعمل له داونلود. المهم لازم اعمل له داونلود على فولدر معين عندي، واعمل له اكستراكت والقصه دي. تحت امركم في اي وقت. ولو في اي حاجه دكتوره نيفين معاك في اي وقت. السلام عليكم.
وعليكم السلام يا فندم، شكرا لحضرتك.